Dear students, welcome to the medical visualization lecture. We discuss today another round of interaction techniques for medical visualization. Visualization here really means that we do not only generate nice images, but that we want to support an exploration process, an interactive process that leads to additional information about the patient data. The images that you see here in the beginning, entitled with final leg alignment and femoral planning, are part of clinical practice in operation planning. This is software provided by the German company BrainLab that provides quite nice interactive solutions with techniques in order to measure angles and distances that are important in order to select the right implant for orthopedic surgery. For example, these examples here are from orthopedic surgery. So this was a little bit of a preview. The outline is basically structured according to the interaction tasks that we will discuss. It starts with the most simple thing, namely to select objects in volume data. We go on and discuss a little bit more in detail the insertion of clipping planes. We have already seen several examples of clipping planes, but now we go a bit more in detail about the interaction. Clipping planes is a very simple example to define a cutting area. We discuss some more advanced strategies like slab rendering or box clipping. Even more advanced is virtual resection, where we want to define an arbitrary resection area, for example, in order to plan or train a surgery where we want to remove this particular region of an organ, for example, as a consequence of a tumor disease where we have to resect the tumor, a safety margin around this, and perhaps even more tissue in order to respect vascular territories. Implant placement, that was basically the topic of the first two images I have already shown, is something we will also discuss a bit more in detail with different examples, for example from middle ear surgery, where the implants serve to restore the hearing ability of persons. A little bit more in general, we discuss measurement tasks, interactive and automatic measurement that can also be combined with each other. And the measurements relate primarily to geometric measurements, e.g. to distances and to angles. And finally, we discuss path planning. Path planning is important for various interventions, for example, to treat a tumor or to take a biopsy of the patient. Several criteria have to be considered when choosing a path for a needle, and we discuss interaction techniques that are useful for such situations, and also visual support that makes the task for the physician a bit easier. How can we select something in volume data? Of course, at least as a theoretic possibility, we can specify coordinates. Give me the object that is at voxel 20 in x direction, 52 in y direction, and 75 in z direction. If I have segmented data and I look in my information with respect to the segmented data, it tells me which object is visible there, and this is highlighted as a consequence, and maybe I can start some interactions for the selected objects. That's a theoretic possibility. It would require that I can assign as a user such numerical values, such coordinates to objects, which is typically not the case. We need something that is more intuitive and in particular which is more visible, visualization oriented. The term that is used for any direct manipulative selection technique is picking. We select something via picking. That means we make a gesture to this object and select it this way. The problem, of course, in 3D data is that we have some kind of ambiguity. Even if we select the right pixel in x and y direction, there are different objects at this point in the image plane depending on the Z component. Yeah? So as a consequence, one could think about providing orthogonal views, 3 orthogonal views, and the user selects an object visually in these 3 views. That would be possible. As another strategy to resolve the ambiguity, we could also combine selection with transfer function design. That means we consider only those objects that are currently visible with the transfer function settings that we have. Then the question is, of course, what does it mean something is visible? Of course, it means when something is completely transparent, it is not visible. But if it's only slightly opaque, maybe it's also not so visible. So that this could be combined with a threshold for opacity. We can also restrict the selection to segmented objects or to a certain volume of interest that can be defined, for example, with a bounding box. Yeah. So here's an example. We see 2 vascular structures, namely the arteries and the portal vein, both arterial vascular structures in the liver. The user wants to select one of them, so he selects a point that belongs to one of them. They are fully opaque, both. Yeah. And whenever I select something that is rendered in red, it corresponds to the hepatic artery, and if it's rendered in blue, then it corresponds to the portal vein. Yeah, so that is quite trivial, although the structures are quite close to each other. So there are points where I may not select the structure that I actually want to have. Yeah, but basically this works quite well. Things get more difficult in case that we have semi-transparent visualizations. Yeah, if we select a point like this one, then probably we want to select this object here. Yeah, this is the only visible object here, the surrounding organ, so that's fine. Yeah, if we select something that is here, for example, or here, it means it belongs both to a vascular structure, but also to the surrounding organ. So the question is, what is it that we likely want to pick? A naive implementation would say we consider as selected the first object that we encounter along the viewing ray. That would mean that we always select the liver, the surrounding organ. Yeah? The surrounding organ is always in front from the viewer, in front of any internal structures like tumors or vascular trees or the gallbladder or whatever. Yeah? So that is probably not a good idea. Intuitively, one may think that in case of a surrounding structure, in case of any ambiguity, we should select the smaller structure that is possible here. Yeah, so we would prefer smaller structures, and we would prefer structures that are opaquely rendered, that have the higher value for opacity. Yeah. So that is how we can evaluate the structures that we encounter along the picking ray. Consider transparency and the size of object, and choose a strategy that prefers small and opaque structures. Yeah, that is something that we have did in our group. It was part of Konrad Müller's PhD thesis, and it works quite well for structures like this one here, where we have surrounding organs shown semi-transparently, otherwise we would not see anything inside, and we have opacally rendered internal structures. Yeah, for all structures that you may want to select here, this works as expected and is quite well. So if you come up with a new technique, visualization technique, interaction technique, or analytical technique, it's a good idea to think about the limitations. Where could it fail? Yeah, and we thought we did this, of course, and here's an example where it could fail. You may recognize these anatomical structures here as well. That is the spine with all the different components that it has. Yeah, the prolapse here in between. And here is a region that was specified by a physician as an area where he wants to look in more detail. So that is a user-defined additional object. Here are some muscles and so on. So this one is semi-transparent, and here if we want to select this structure, this would not be possible with our algorithm that prefers opaque and smaller objects. Yeah, so here it would not work. That is a rare example, but if you have semi-transparent objects in front of similarly large opaque objects, there is no single point where you can select this structure. So that's bad. Yeah, it should never happen that the user is not able to do what he wants to do. It may happen that it takes a bit more time and is a bit more cumbersome. That is acceptable, but it should be possible. So what can we do? A general strategy could be, in case of an ambiguity along the picking ray defined by the currently selected pixel, we can provide a small pop-up menu that includes the names of all objects that are at this particular point. Yeah, so here it is a venous structure, an artery. Somewhere behind are also the bones, and one of the structures that is also at this pixel position is the musculus sternocleidomastoideus. This is the large muscle that connects here the head with the neck. Yeah. So, and then of course the user can easily decide which of them is it that she wants to have. You also see that we try to make this task really as easy as possible. We did this by integrating an icon for each structure, and in particular a color for each structure. So red stands for the arteries and blue for the venous structures, and this reddish blue here stands for muscles. Yeah, so that is how we can resolve the ambiguity in selection processes. A more advanced method was introduced by Peter Kohlmann and colleagues at the Technical University of Vienna. Yeah? He came up with the idea of analyzing many data sets, as people would do it now in the area of, in the time of deep learning. And he came up with typical profiles for vascular structures, skeletal structures, and some other anatomical structures. Yeah? What is the intensity profile? It depends on the size of the structures, on the gradient at the borders. Yeah? And when the user selects something, then he could choose before which structures he prefers, and the best match is then determined automatically in order to select, hopefully, the right object. I have not tried this system myself. I guess it works in most cases quite well, a little bit like our approach. It will not work perfectly in 100% of the cases. Yeah? That cannot be expected since the anatomical variability is just too large. So probably in addition, this pop-up menu idea of presenting the objects that are at a particular point may help in cases where this approach does not select the intended structure. Alexander Wiebel came up with an idea that I like a lot. It's called visibility-oriented picking. Visibility-oriented picking. And his major observation is when people want to select something in a 3D visualization that contains transparency, they prefer to select structures that have high opacity values. In case of ambiguity, this is an important information. Yeah, that was also our observation leading to the approach of Konrad Müller, and Alexander Wiebel took this a step further to select, if possible, the most visible object. Yeah? So, and the high visibility results from a sequence of voxels. So typically not only one voxel along the picking ray belongs to a certain object, but several voxels, and the cumulated opacity should be high. So that does mean that it is not necessarily the case that an object where one voxel has a very high visibility due to the transfer function setting is selected, It could be that another object with a little lower but on average higher visibility and opacity is selected. Yeah? So this analysis relates to a ray profile, that is the picking ray starting at the point where the ray enters an object, and then cumulative opacity is analyzed, and you see this object here, object B, that has the highest increase in opacity, so that would be the object that is selected. Not this one and also not this one. Yeah, this is a large object. Many voxels are along this ray, um, but the increase in the y direction is smaller than for object B. Yeah, that is what I wanted to say to simple selection techniques. Let us discuss clipping planes. We see two examples here. A brain MRI dataset is clipped and a CT head dataset. Yeah? Here, 6 clipping planes together form box clipping. That is, by the way, also what is typically supported by the graphics hardware. Yeah? The placement of 6 clipping planes and the rendering with respect to these 6 planes. Here on the left, on the right, we just have one clipping plane indicated here, and the user may move it forward and backward. The user also needs facilities to change how it is tilted, of course. Yeah. So that was really done here for surgical planning. The yellow structures here are swellings in the nasal areas, in the sinus areas of the nose, and the patient could not be treated with drugs alone. That was not sufficient, and he needs surgery. And surgery in this particular example was difficult because the regions where the swelling needs to be removed surgically is quite close to the optical nerve. Yeah? And you can imagine that damaging the optical nerve is something that should not happen in surgery. Yeah? So therefore that was planned. Yeah, a little bit more detail on clipping planes, how this could be done even in a more sophisticated way. Yeah, we can restrict the volume before applying a clipping plane. We can use one cutting plane and move it through the data set, and we are interested in seeing the information at the clipping plane, a little bit like slicing to 2D data. And even more in this direction is slab rendering. With slab rendering, we have two clipping planes parallel to each other, and they are moved together. Yeah? When the user wants to move this slab, that means that both cutting planes are moved. That can be applied to direct volume rendering, and even more frequently I have seen that it is applied to a maximum intensity projection. Yeah? If this is done, it is a little bit of a trade-off between a 2D visualization and a 3D visualization. We discussed in one of the earliest lectures that the benefit of 2D visualization is that you see a lot of detail. That's nice. Yeah? Whereas the 3D visualization gives you an overview, but it summarizes many information within one pixel. Yeah? The whole information along one viewing ray is summarized in one pixel. And that necessarily means that you lose a lot of information. And if you create instead a slab rendering, where the slab has maybe a size of 2 centimeters, and 2 centimeters corresponds to 30 slices, that is something in between. You do not see everything, like if you look at all the slices, but you lose less information than in a 3D visualization, where you integrate over several hundred slices. Yeah, that's the idea of slab rendering. Yeah, we have already seen that several clipping planes can be combined with each other, up to 6, forming a box around the structures that are interesting. Yeah, let's have a look at slab rendering. Here we see such an example, and actually the slab is quite thin. Yeah, that's only above 1 centimeter here, approximately 1 centimeter, that you see from lung tissue Two of these slab renderings have been created by a radiologist from University of Aachen, and you see a lot of details in these slabs, and the user can move this forward and backward with the scrolling wheel of the mouse in order to change this. So it integrates information from a few adjacent slices. And this technique is really used in clinical practice. It's also recommended for certain situations in clinical practice. So that is a quite nice example of a 3D visualization. Here's another example with thicker slabs showing larger portions of CT thorax data, giving a better overview of the structure of the bronchial tree here, for example. Yeah, and here this shows obviously the lung tissue. A nice idea that goes back to Ulftide is selective clipping. Selective clipping is something that, that cannot be observed in reality. Yeah, if I clip something in reality and cut everything away on one side, virtually everything is moved away. Virtually, I could be interested in generating visualizations where only some structures are selectively clipped, whereas others are not. Yeah? And that was the idea of Ulftide and colleagues from the Boxelman group in Hamburg. And here's an example where they applied this with several clipping planes. They show portions of the brain, but also the ventricles in the brain. And their position becomes really clear very well with this combination of clipping planes. Yeah? So the clipping planes do not affect the ventricles. We have applied the same strategy for surgical planning. This is again an example where a patient has swellings in the nose that need to be treated, and the swellings are on one side only, at least in this example. Yeah? So we decided that we apply a clipping plane in such a way that on one side of the clipping plane we see the skeletal structures which help us to understand the spatial orientation and position of certain objects, whereas in the other half the clipping plane really avoids that the skeletal structures hamper the view to the pathological structures that we are interested in, and also hampers the view to the optical nerve that is important for surgical planning. Yeah? So if the user would move the clipping plane, that would affect the skeletal structures only, not the segmented objects that we also have. Yeah, similar ideas were discussed by Diaz et al. Spanish group. First you apply a clipping plane, that was done here, and then you may select structures that should grow, should be extruded according to the information that is available about these structures. Yeah? So here, for example, you see the skeletal structure inside the legs. Yeah? And here with the same technique, this selectively clipped visualization has been created, showing the hand anatomy quite well. That all lives, of course, from the interaction. Yeah, that you can easily switch between these views where structures are extruded or not. Yeah, then let me describe virtual resection, an interaction task where the user defines an arbitrary 3D area that represents resection. That could be useful for therapy decisions, could also be useful for quantitatively analyzing this resected area and to give the user an information about the volume of the planned resection. Yeah? So if you, for example, want to remove a part of the liver as a consequence of tumor surgery, the question is, what is the volume of the removed part and what is the volume of the remaining part of the liver? Not only the absolute values may be interesting, but also the percentage. Yeah? And that is an information that is directly useful for a surgeon when she wants to understand whether this type of surgery is feasible. Yeah? Virtual resection type of interaction can also be used to to correct a visualization, to selectively remove something that just disturbs the interpretation and assessment. Yeah. So first we have to specify the virtual resection, and then probably we are not immediately glad with this. So this leads to the situation when we want to modify an initial virtual resection. Yeah. For working with such a tool, we really need fast updates, very high performance of the rendering system. This needs to be realized efficiently, because otherwise, yeah, I have not the impression that I really control this type of resection. I may have to wait, and that's really disturbing in such a situation. Yeah, let's discuss some ideas for virtual resection. One easy idea would be that we define first an area in the image plane, maybe by drawing in the slice, yeah, a contour, and then we specify that this should be the basis for an extrusion. Yeah, that means we have our contour and we extrude it in the Z direction, maybe through the whole data set. Yeah, this is a kind of virtual resection that I have seen in Radiology Workstation. It may be used in order to get rid of certain structures that are disturbing. Yeah, their accuracy is not so important. You just want to get rid of some structures that hamper the view on the structures you are interested in. If you are really interested in the resection volume and its shape, yeah, this is not a very good strategy. So one technique I've tried 20 years before was to use something like an eraser in 2D. Yeah, you have a certain geometric shape, maybe a small sphere. You have 3D interaction techniques to move this 3D shape, and whatever this the tool touches is removed. Yeah, so that's possible. You can define any resection volume with this technique. So in this sense, it's powerful, but in another sense, it's not so powerful, because this interaction is quite tedious, and easily it happens that you leave some holes in the area that you actually wanted to remove. Yeah. So you can also draw in the 2D slices, and in contrast to this first idea with extrusion, you draw not only in one slice, but let's say in 5 or 10 slices. And what the system should do is, in a kind of interpolation process, this should be a shape-based interpolation process, define the resection area in any slices in between. That's also possible. Yeah. And a final idea, and that's the one where I think that's the most promising one, is to draw the resection on the organ surface, and thus to roughly define how it should be resected. Then a plane is fitted to what you have drawn there, and you may interactively refine this plane. Yeah, we named this technique virtual resection with a deformable cutting plane. You will see it in a minute. So I think I have explained the extrusion idea well enough. There's not so much to tell about this. Let's look a little bit more in this eraser idea. So what are the specific interaction tasks that you have to accomplish here? Of course, you have to move the eraser, and also you typically want to change the scaling of the eraser. Obviously, the smaller the erasure is, the more accurate you can define a resection volume. But the smaller the erasure is, the more time it takes to define a larger resection volume. Yeah. So maybe a combination is that you first roughly define the resection with a larger eraser, and then make it smaller for the fine-tuning process. So this can be supported with 3D input, yeah, where you have, for example, a 3D mouse that you can rotate and tilt in 3 dimensions. It would benefit even more if you have bimanual input. Yeah? So you could use one hand to specify the translation of the erasure with a 3-dimensional input device, and another hand may be useful in order to rotate the whole scene, and with this the view on the anatomical structures. That's often necessary in order to control what you have actually removed also in depth. Yeah. And the prototypical system that we developed at that time provided such bimanual interaction. So I said already, the drawback is that it may easily happen that there remain holes in your resection volume. This could be avoided in a post-processing process where you, for example, apply dilatation, or there are even filters, close hole filters for 2D and for 3D data that work not 100% as you expected in all cases, but in many cases it's quite reasonable. It could be useful to see the resection volume in the 2D slices, in particular if it is for something really important like surgery planning. So here you see this tool in action. Yeah, this was a tumor, some vascular structures in the surrounding, and yeah, this was removed. Basically, I asked the surgeon here to simulate a real resection of this tumor in the periphery of the organ. So basically, he defined here a resection volume that defines the tumor with a 1 centimeter security margin in all directions. Yeah, here you see this tool enabled. The two visualizations here are similar. It's the same viewing direction, but here you see that the skeletal structures are also shown to provide more context and to help to better interpret this situation. That was the view that was actually used by the surgeon in order to resect something. Yeah, he just placed the resection tool away from the liver, not to hide something. Yeah, these are the interaction facilities to change the viewing direction. So that was adjusted with one hand, and the other hand moved this tool. So there were also different resection types. So here a wedge type resection could be defined. Yeah, of course this is not restricted to a sphere. Yeah, so that was not bad, but it was not the end of the story. It was not so successful that we really made it part of the system that the surgeons regularly used. Yeah, I just want to mention that similar techniques have been used by others as well. Partially, I became aware of this even later. So here you see a kind of virtual resection for surgery training within the Voxelman project, where yeah, high quality medical volume data was labeled and used for anatomy and even for surgical training. And the group here came up with good ideas for displaying these resection areas really with high quality, namely by rendering the resection plane with subvoxel accuracy. Yeah? So this idea was later illustrated by Bernhard Flesser and colleagues. So imagine that this is the resection area specified with a virtual scalpel or another tool. Then it's not a good idea if full voxels are either completely shown or completely removed. Yeah, but instead something like this should result. That means it should be adaptively sampled to represent the cutting surface as accurate as possible. Or to say it slightly different, at least as accurate as it is necessary to provide the impression of a smooth resection plan. As accurate as possible would probably last too long. Yeah, this is realized with the technique that I have described in the volume rendering lecture from Ulf Tiede, where we briefly discussed his high quality rendering of attributed volume data. This same technique is used here as well for showing resection areas with subvoxel accuracy. Yeah. So and here you see results of this. The virtual scalpel as the tool to define virtual resections. I think that fits quite well. That's a nice metaphor. And here you see indeed high quality subsurface renderings of the resection surface. So I think that's really convincing. So I told you that one further idea to specify a virtual resection is to draw in the slices and do this, for example, every fifth or every 10th slice, and to let the system interpolate in between. Yeah, we did this, in fact, in our work, in particular for defining living-related liver transplants. That means when the liver is split in two halves, it's the liver of a living patient, and there is a donor and a recipient. The recipient has an end-stage liver disease like cirrhosis. The donor is typically a close relative, for example, the son of the recipient, which increases the chance considerably that the organs fit genetically well enough to each other. The blood group must fit, and so on. Yeah, so that is a quite challenging process. You really have to understand very well where to cut the liver. Obviously, both the donor and the recipient need to have enough liver volume so that the liver can work properly. But that does not only mean that there is enough volume in the sense of milliliters. This should also work properly. That means the resection surface needs to be carefully defined with respect to the hepatic artery, the portal vein, and the liver vein. Yeah, and that was drawn in the slices, as you see here. So that was something that the user did, not in every slice, but approximately every fifth slice. And with shape-based interpolation, a whole volume was created, and these were set automatically apart from each other, so that when rotating the camera, the user can really look at this resection volume and see whether this is a suitable structure. This could be combined with the idea of selective clipping, so that the user really would see the vascular structures that would be directly affected by this kind of cut. Yeah, so that's not bad. Yeah, another technique also developed by Olaf Konrad Ferse at Fraunhofer Mewis is what we entitled as virtual resection with a deformable cutting plane. And that was motivated by the observation that in surgery, the surgeons draw on the organ surface once they have prepared it where they want to cut. Yeah, they draw this on the surface of the organ, and that is what they did here as well. And this defines an initial clipping plane that is fitted to the drawing on the surface. You see that this clipping plane is designed such that a grid is overlaid. The grid has a higher or lower spatial resolution, and that can be used in order to refine this initial clipping plane, yeah, to adjust certain positions. And if the user is ready, not only the resection volume, of course, is shown visually, but also quantitative information is derived, like the volume here would be 482 milliliter and 1246 would remain in the donor. Yeah, would remain in the patient. So that is tumor surgery. Here we don't have a donor and a recipient. Here we just have one person, and that is the removed area. Some details on how does this technique works. If you are interested, I cited the paper from Olaf Konrad, but I want to comment a little bit, at least on the major ideas. When the user draws on the surface, yeah, we sample this movement. So as a result, we have a set of coordinates. That means we have a point set. Yeah, and all these points have coordinates in x, y, and z direction. To this point set, we apply a principal component analysis. And the principal component analysis gives us three eigenvectors, yeah, that defines a local coordinate system, and eigenvalues corresponding to these eigenvectors. Yeah? So lambda 1, lambda 2, and lambda 3 are the eigenvalues, and E1, E2, and E3 are the eigenvectors. And how this information is interpreted. The eigenvectors E1 and E2 correspond to the two largest eigenvalues. Yeah? And basically our plane is the plane defined by these two eigenvectors, E1 and E2. They are orthogonal to each other and define the basic orientation of the plane. So, but what the user has specified was not exactly a plane, and we should define a plane or an area. It's not really a plane in the strict sense, that better fits to what the user has specified on the organ surface. Yeah, that means we use this grid and displace the points along the grid in the direction of eigenvector E3, that is the eigenvector corresponding to the smallest eigenvalue. Yeah? And these translations and displacements are carried out in such a way that the defined plane, the deformable plane as we call it, fits as good as possible to what the user has specified. So that is the initial process, step 1 to 3, and then the user may interactively adjust the points. Yeah. So this is the attempt to show in a sketch what I have just described. Yeah. Here is what the user specified on top of the organ surface. That is the plane that is defined with E1 and E2 eigenvectors, yeah, following basically this line, and then the points along the overlaid grid are displaced in such a way that they fit as good as possible to what the user has specified here. So, and then let me comment a little bit on step 4, that is the interactive adjustment. Yeah, maybe I go back here to this grid. What the user is doing is to select a point here on this grid, a grid point, yeah, with the mouse cursor, a kind of picking. And once this is done, this point is highlighted and it can be moved forward or backward, leading to a displacement of this point. And then the question is, of course, what is the influence of such a displacement? This could be a very local influence. That means we had a plane before, now we move one point and we go high up steeply and steeply descend afterwards, then the influence would be very local. It could also have a larger or even a global influence, meaning that basically all points of the plane are a little bit moved in this direction. Intuitively, we would expect that the influence decreases the further we are away. Yeah? When I move the point from one position to another one, yeah, defining a certain distance, a few millimeters, then adjacent points should be translated less, and even points that are even further away should be displaced even less or not at all. Yeah? So we are searching for a function that models this, and there are different alternatives that could be chosen. What we did was to use the cosinus function. Yeah? The cosinus function has its maximum value of 1 for the value of 0. Yeah? That means at the point where we have displaced something, a weight is computed according to the cosinus function. This weight is 1, so we displace the grid point exactly as the user has specified it. And for the grid points in the surrounding, we reduce this distance according to the reduced cosinus values that we get when we deviate from 0. Yeah? And the question is, of course, how to scale this cosinus function. There is no solution that always works in the way the user expects it. So we did it such that we specified, of course, a default width of the cosine function, so the area of the cosinus function where it is different from 0. And the user may change this influence area, this influence zone with the mouse wheel. Yeah, he may slightly adapt it to allow smaller or larger changes. And here you see an example where this was used. That was an initial cutting plane defined with the technique, with the principal component analysis. Here you still see what the user has specified. You see a tumor and some vascular structures in the surrounding. And here you see that the user um, adapted this deformable cutting plane. Here you see it. Yeah, that was flat here, and here the user has adapted it in order to translate parts of the resection plane. The major motivation for the user to do this in our user study was in order to adapt where to cut in the vascular structures, whether certain branchings of a vascular structure should remain in the patient or should be part of the resected volume. Yeah. So this would be an example of such a clipping plane, and the user may draw here and change things. And as a consequence of the influence zone, the areas of the grid that are actually affected would be drawn in another color, yeah, to convey to the user what actually has changed. So we published this in 2004, and exactly in the same year, Stefan Zacho at the Zuse Institute Berlin submitted his PhD thesis, and what he did was, I simplified a little bit, but not too much, was basically the same. Yeah, he developed a very similar technique for a quite different purpose, namely for oral and maxillofacial surgery. That means in case of accidents or severe diseases, it may be necessary to change the position of the jawbone here. And yeah, that is of course a quite delicate process because it has not only functional consequences for the patient, but also changes the way how the face looks like. So together with colleagues, they were able to simulate how the soft tissue, the muscles of the face, change in response to such a movement of the bones. So this could be taken into account in pre-operative planning together with the patient when it was about to decide which strategy of surgery should be actually chosen. Yeah? But the way how the resection was defined was quite similar, based again on a principal component analysis. Here you see the author of this work, Stefan Zacho, and you also see that virtual resection really benefits from carefully designed user interfaces, and yeah, pen-based interaction could be an example of a quite appropriate type of interaction. Also, this haptic feedback device could be quite useful. Yeah. So here you see a graphics tablet that is used in order to specify and draw the resection area. Yeah. Here you see the resulting visualizations. So let me briefly compare these different methods. We have seen the resection with erasers, which is, I would say, hardly manageable and typically not precise enough. Yeah, that was the technique that I developed, so I'm allowed to criticize it. Resection through drawing in the slices is very precise, but to do it precisely, it requires quite considerable effort. So the physicians that we were cooperating with used these techniques as long as nothing else was available, but it was not ideal. The last technique I have shown, the resection with the virtual cutting plane, that was more successful, although the interaction is more challenging, but it is more feasible, it is faster once you know how to use it. Yeah, so this is a little discussion of these different methods. Virtual resection has even been used in a virtual reality setup, so I would say that this was really pioneering work by Bernhard Reitinger and colleagues at Graz University already 14 years before. They came up with virtual reality solutions where you could also specify cutting planes, deform them in order to define surgical planning processes. Yeah, so at the end of this lecture, I want to describe some volume exploration techniques, local volume rendering. So what you can do is to show more detail in a certain region that is particularly interesting. For example, the area around a tumor or the tumor itself with its shape. And local volume rendering may also be used in order to benefit a subsequent segmentation process. So you have to define first a local subvolume, that's one interaction task, and a local transfer function for this subvolume. What we see here is box clipping, where volume exploration is supported by providing the user with a box that can be moved in the data set. And you see that for the area that the user is particularly interested in, another transfer function was chosen in order to clearly show the vascular structures. Yeah? That was a type of diagnosis for patients with cerebral aneurysms, and it's essential to understand where these aneurysms are, how they are supplied, how difficult it could be with a catheter to reach this vascular structure, and of course also to assess the shape of this aneurysm, the size, the specific inflow and outflow regions. Yeah? And this kind of detail and context rendering could be quite helpful for this. Here you see another example of local volume rendering to evaluate the surroundings of a tumor. So these regions here were automatically defined. The user could adjust this, but the suggestion was done automatically, namely by using the bounding box of a tumor with a certain safety margin in all directions. Yeah? And this gives you an impression of the surrounding of this tumor. It could show you the vascular supply in the region of the tumor. It is a kind of hybrid rendering, meaning that the tumor is shown as an isosurface. It was carefully segmented before, so the surface should reveal this segmented structure with some smoothness applied, as you may guess from the visualization, and the surrounding structures are shown with direct volume rendering. Yeah, so with this I would like to thank you for your attention. Next week we discuss cutting and deformation, as well as some more advanced interaction techniques like measurement and path planning. Thanks for your attention.